Yes, Dr. Aditya, Dr. Divya. Very good evening. Can we start with the first question? I'll try my best in the next 2 hours. We will be doing all the whole anatomy of ear with basic concepts of clinical disorders.
Yes, is audio video fine?
Yes, very nice. Kindly update in the chat box. Question number 1 in front of you. Let us start. When making a post-auricular incision for a mastoid surgery in an infant, the incision should make more posteriorly than in adult. For what? Yes. Anyone who can update what is the right answer? Why we should do? What is the difference in the mastoid surgery of a newborn against mastoid surgery of a adult? Yes, Dr. Shea. Any query? Kindly write in the chat box. So what will be the best possible answer of this MCQ? Mastoid antrum is located more posteriorly. If it is located more posteriorly, we should not extend the incision. Our incision should be more anterior. It means the option A is here. First option is here false statement. The mastoid is small and facial nerve may exit directly from the cortex. Absolutely right statement. Because the tip of the mastoid is absent, the facial nerve is exposed. Therefore, we are giving the incision more posteriorly and slightly we stop at the above level. We never extend to the lower edge. Can you update in the chat box, beta? Is audio video fine? Everything? Kindly update in the chat box. Yes, all the students listening to me, kindly update the best possible answer in the chat box and let us use these 20 MCQs, 80 options to learn a clinical anatomy of external ear, middle ear, all the inner ear basic concept. Mastoid process is absent. Therefore, we will extend our incision like I'm giving in this slide. Incision A, incision B. Which incision will be preferred in a newborn? The incision B will be preferred in a newborn because the tip of mastoid is absent. Am understandable? Option C, option 3 and 4 are nothing to do with your post-auricular incision. Have nothing to do with post-auricular incision. Is this concept clear, beta? Is this concept clear? Fine. Thanks, beta. Everyone. Dr. Mohammed, thank you, beta, for updating the chat box. So this question, let us use this MCQ now. I'm showing I have tried my best to compile all the images with which we will crack all the basic anatomy concept of middle ear, external ear. This slide is the most important slide. If we are doing mastoid middle ear surgery, what is the approach? Always remember the approach is from anterior to posterior, posterior to anterior. The infection is moving from anterior. If examiner asks you about infection, it is anterior to posterior. I'm writing the keywords better. And if the examiner is asking you surgery, that is posterior to anterior. Just remember. So we open the mastoid. We remove infected air cell of mastoid. Then we enter into the middle ear via adductus. So our anatomy should be strong. Okay, who is communicating? Which part of middle ear is communicating? If you focus your eyes on the slide, that is your apitympanum is communicating. It is not the whole mastoid which is communicating. It is the upper part. And we are coming from adductus. Always be confident, beta. We are coming from adductus. Then, so it is your antro to attic approach. Why infection? CSM will be from attic to antrum, attico-antral. That is your unsafe ear. So if you are master of the basic concepts, you will be very comfortable with the MCQs. Clear? So we open lateral wall of mastoid, and this is I'm giving you post-auricular incision. We are entering. Now I am drawing one basic line diagram of middle ear, external ear. This is my pinna, this is external auditory canal, this is middle ear. So what is the route of surgery? Route of surgery is from lateral wall of mastoid into middle ear via adductus. Always remember. Can you suggest me, can I call it as posterior tympanotomy, opening the posterior wall? So beta, whenever we are operating the middle ear mastoid, just remember we are working on which wall? We are working on the posterior wall of middle ear, which is equal to anterior wall of mastoid. Anterior wall of mastoid. Is this clear, beta? Is this concept clear? Any query till this point, the first slide? Any query? Coming to the next slide, which are the three important incision which we are using in our middle ear mastoid surgery? So I'm showing you the incision number 1. Yes, anyone who can tell me where I'm using incision number 1, incision number 2, incision number 3? Any student? What is 1? Let's see who will reply first in the chat box. Beta, what is incision number 1? I'm giving a incision along the annulus. I'm just trying my best to give you all the best possible anatomical concepts of middle ear, external ear, with the help of this first MCQ. All the students who are joining now, we are on the very first MCQ. So I am giving a incision along the annulus. Can you tell me, beta, what will be the drawback of this incision? Drawback of this incision will be I will not have the complete exposure of the middle ear. I will have exposure to only small area of middle ear. Anyone who can tell me what is the name of the incision and where we use this incision, which I am showing you in the slide? Yes, absolutely right. This is your Rosen incision. This is Rosen. Where we are using? We are using for stapes surgery. Underline the alphabet S. It is for stapes surgery, autosclerosis. So if a patient suffering from autosclerosis, we give a Rosen incision known as endomeatal, Rosen endomeatal incision. Done. And what is this one? Incision number 2. Incision number 2 is your post-auricular. This is most common incision I'm using for middle ear and mastoid. Most common incision for middle ear and mastoid. No, Dr. Shah, it is not for CSM. Incision number 1, it is for your Rosen incision. It is for your autosclerosis. That is, I want to remove the sclerotic part from the stapes. Clear? And the third number incision I am showing you is Lempert incision. L-E-M-P-T, Lempert. This one is your Lempert incision. Lempert, we call it as Lempert and oral incision. At the end of the pinna, we are giving the incision. It is used for pediatric patient. Always remember, incision number 3 is used for pediatric patient. All the students listening to me, kindly use the platform chat box to respond, reply. Even if you are replying wrong, hardly make a difference, but we will rectify, we will learn the concept, every student. And incision number 2 is Wilde. Absolutely. This is Dr. Divya, it is Wilde. Yes, Dr. Jyoti, it is Lempert incision. Lempert post and oral incision. It is used for pediatric patient and it is used for canaloplasty. Can you tell me any student in which patient I do canaloplasty, repair of the canal, when the patient is not responding to the medical treatment? Which patient we do canaloplasty, beta? Which patient we do canaloplasty when the patient is not responding to medical treatment? I give you a clue. Which medical treatment? Patient is not responding to keratolytic agents. Can you tell me where I will use, where I do canaloplasty if the patient is not responding to keratolytic agent? Which patient we are using keratolytic agents? Keratosis obturans. Keratosis obturans. Yes. So if the patient is suffering from keratosis obturans, I have given one MCQ on this topic of keratosis obturans. So just remember, we will go for canaloplasty. I hope you get, no, not ASM. No. Canaloplasty, beta, repair of the canal will be done for keratosis. Clear? Coming to the question number 2, where Dr. Aditya, not malignant otitis externa. Malignant otitis externa, which surgical procedure is done? Debridement. Where debridement will be the better option. It is keratosis obturans. Okay, very nice. Everyone is responding in the chat box. The best part. Excellent. Coming to the next MCQ, let us read each and every line and try to apply on the anatomy as well as physio segment. Clear? What is the motive of this session? Motive of this session is to give you the message, whatever basic science is required for your clinical MCQs, we should complete with the help of these 20 questions. So let us start. A girl seen for the school physical examination. Audiometry was performed, revealed at 30 decibel. Audiometry and everything I will be discussing in the next session, but I want to explain you some concept of inner ear. That's why I'm using this word. So there is audiometry, there is a loss of 4000 hertz. So what is the first important MCQ given in the question is the examiner is giving you a clue, 4000 hertz. So beta, all students going for ENT MCQ, 2000 means heart notch, 4000 means boiler's notch, means noise induced trauma. The patient is having some sensory neural hearing loss. Patient is reported to spend several hours in a day listening to the music. Means somewhere noise-induced trauma is there. Previous night, she had some several hours of rock concert without wearing hearing protection. Clear? Young patient. Afterward, she noticed that the ear were having ringing sensation, felt like there's a cotton in them. Patient is having vestibular symptoms. It means patient have some acute trauma in the inner ear. Acute trauma in the inner ear. Can you tell me, if there is a acute trauma in the inner ear, patient will end up with sudden sensorineural hearing loss of 30 decibel is there. There is a possibility, but examiner is giving you pointing at 4,000. So basically the patient is having some history of noise trauma, followed by patient have acute trauma last night, and now the patient is coming, the hearing is coming back to the normal. Capital letter, all the students listening to me, noise induced trauma is reversible. Yes, what message we are getting? It is reversible, beta. In physio they can ask you which of the following is a false statement. It is irreversible, is a false statement. The hearing returned to the normal. In noise induced hearing loss, which part of the cochlea is primarily damaged? So just try to learn which hair cell are more at high risk, more susceptible to get damage. That is your outer hair cell. So if the examiner is giving you this audiogram, so it is a loss is at 4,000. It is, I am showing you some boiler's notch. I am showing you boiler's notch. Answer will be your outer hair cell. Now just try to learn which are the MCQs where the outer hair cell will be a right answer. The outer hair cell, always remember, they are at high risk. They are always more in number. There is 3:1 ratio. If there is one inner hair cell in physiology, there will be outer 3 hair cells. Outer will be 3 hair cells. They are always motile, more in number. They are motile. They are efferent fibers. Always remember. And they develop late in the intrauterine life. Late development is there. So these are the 5 important points. They are at the high risk. Every student listening to me, revise in the class only. They are at high risk. They are more in number. They are motile. They are afferent fibers. They are late. Now, OA, this outer hair cell, is a right answer for 3 MCQs. Which are the 3 ENT MCQs? Now we have learned anatomy, physio part. These are the physiology features of your outer hair cell. Now we are entering into the ENT segment. If examiner asks you noise induced hearing loss, I will go for outer hair cell. Yes. If the examiner asks you for some ototoxicity, outer hair cell. If examiner asks you about autoacoustic emission, which part of the cochlea give autoacoustic emission, answer will be here. Outer hair cell, absolutely yes. Any student who can tell me, sitting with me, where the answer is inner, can you tell me some MCQ where the answer is inner hair cell? Anyone? Which clinical MCQ will be using inner hair cell? Absolutely, Dr. Devya. North Korea king, very nice. North Korea king was inner hair cell. We are writing the feature of outer hair cell, but yes, the slide we discussed in the classroom, it helps a lot. Now, can you tell me inner hair cell? Which is the only one MCQ where answer is inner, clinical MCQ. I'm not asking the feature. Anyone, any student who can write in the chat box which MCQ answer is inner. Just remember electrocochleography. New point. In physiology, they can ask you electrocochleography. We take the ratio of summating potential of cochlea and action potential of it. Now they will ask you summating potential of what? Summating potential of which part of the inner ear? This is again one of the new MCQ. Summating potential of cochlea. Everyone listening to me, write in a nice way. Summating potential of cochlea in electrocochleography. Is of which hair cell? It is inner hair cell. No, drug induced hearing loss, again it will be outer. Drug induced ototoxicity, your noise induced trauma, everywhere answer will be inner. Outer. Inner will be the right answer for summating potential of cochlea, which we are using in electrocochleography. Done. This concept is clear. 2000 is your Carhart notch. We'll discuss in the next segment. This is now noise induced trauma. What other MCQ in PSM? Because if we are going for next examination, they will be asking you your PSM segment. So which PSM MCQ we can discuss? What is WHO guideline for industries? Always remember, it is 85 decibel, 8 hours in a day, 5 days in a week. So this is your WHO guideline for industries. For noise induced trauma, WHO say maximum limit should be 85. Patients should not work more than 8 hours in a day or 5 days in a week. What is Indian Factory Act? Anyone who can write in the chat box. What is Indian Factory Act? Indian Factory Act is 90 decibel. Rest everything is same. Instead of 85, it is 90 decibel. But if the examiner asks you about city life, what is the maximum limit in the city life? Any student who can write what is maximum limit in the city life? 85 and 90. They are PSM MCQs for noise induced trauma. City life, if somebody asks you, it is 45 decibel. It is 45 decibel. I hope everything is clear, crystal clear. Then coming to the next one, question number 3. A boy was admitted in a pediatric ward with complaint of unable to take feed from birth, having cough, eye discharge, hearing problem, some syndromic findings, regurgitation of milk via nose and mouth. On physical examination, the ear were underdeveloped and they have shown you one image. Clear? Examiner is asking you which grade of microtia the patient is suffering from. So we have important classification of microtia: grade 1, grade 2. This is typical grade 3. So question number 3, dedicated to anatomy of your external ear. So always remember, beta, if it is this is your normal finding. If the size is little bit smaller, it is type 1. If it is the structures are not in type 1, structures are clearly visible. Can you appreciate, beta, how to differentiate from 1, 2, 3, 4? These are 4 grades. So grade 1, the size, just have this image in your mind what I'm explaining you. Grade 1, the size will be miniature form of the normal pinna. But in grade 2, you will not be appreciating the triangular fossa. You will not be appreciating your Simba concha and all those structures. It will be again smaller size and with loss of landmarks. In grade 3, there is a complete loss of. Now if you compare the slide I have given you, that is grade 3. What is grade 2 and grade 3 difference? Grade 2, grade 3, there is a loss of landmarks, but in grade 2 I can appreciate this is lobule, this part is tragus, but in grade 3 even they are not appreciated. Again I am repeating for you, grade 1, beta, grade 1 will be miniature form of the normal, slightly smaller size. Grade 2, grade 3, there will be loss of landmarks, but a significant size of pinna will be visible to you. I am showing you this slide. This is a very favorite topic of your Central Institute. So they can ask you, they can show you out of the, and for grade 4, the sizes you can say not significant, not visible. Pinna is not there. Am understandable? So there will be a small swelling or small, you can say, tissue which will be not completely developed. That is grade 4. Am understandable? Grade 2, grade 3, loss of landmark. Grade 2, some landmarks are visible, some areas are visible. Grade 3 not visible. So these are 4 important grades. So among these, it is your grade 3 which I have given you. I hope you are getting the message. All thanks for all the compliment in the chat box. This logical learning is required for getting good rank. But mug up each and every line. Don't do this thing. If they have given you some classification, like in pharynx we'll discuss angiofibroma, fish classification, Radonsky classification. So some student mug up each and every line of the class, stage 1, stage 2. Never do this. Just apply the common sense and learn. This pictorial memory is always long lasting. Grade 1, Dr. Divya, beta, the size of the pinna is little bit smaller, but all the landmarks are clearly visible. All the anatomical structures are clearly visible to me. Clear? Now I am showing you some slides, because if you're going for Central Institute, they will be asking you cosmetic abnormality. Anotia is absent. Bat ear, you always focus your eyes on the alphabet A. Just remember A for absent, A for anti-helix. So bat ear is your absent anti-helix. BAT, bat, A for absent, A for anti-helix. And ear microtia is smaller, we have discussed already. Loop ear and cup ear, this both slide are same. One is a view from anterior, one is from the posterior. So these are different size of, obviously this can be a important MCQ in ENT or pediatrics. Coming to the next one, what I am showing you, I am confident all of my damn students will reply in the chat box. What I am showing you, I am showing you some congenital anomaly. There is some opening in front of the pinna auricle, in front of pinna. I am waiting for response in the chat box. Can you reply beta what I am showing you? What I am showing you, I am showing you a congenital anomaly of pinna. This is known as pre-auricular sinus. I am showing you pre-auricular sinus. What is pre-auricular sinus? It is incomplete fusion of the hillocks. How many hillocks you have? Sir, we are having 6 hillocks. 3 hillocks coming from the first brachial arch, 3 hillocks coming from the second brachial arch. So if these hillocks, these are 6 hillocks, and if these hillocks will not fuse properly, there will be an opening that is known as pre-auricular sinus. Pre-auricular sinus. Clear? Symptom. What is the symptom? They can ask you a clinical MCQ. Symptom will be ear discharge. And what will be the treatment? Treatment will be surgical excision of this pre-auricular sinus. Now let us use this slide and let us this, if you want to revise the whole anatomy of pinna beta, kuch nahi aata, at least you should remember 2 important points. Can you tell me what I am showing you? Number 1, number 2. These are the 2 minimum must read segment of pinna. What is number 1? Number 1, I am showing you a area which is just below triangular fossa. This is my triangular fossa. No MC. Nobody will ask you, but they will ask you the area below triangular fossa. Area below triangular fossa is your Simba concha. So number 1 is your Simba concha. What is the importance of number 1? Importance of number 1, it is used for mastoid tenderness. If I want to elicit mastoid tenderness, I will use this number 1. What is number 2? Number 2 is just above tragus. No, Dr. Sagar, number 2 is not tragus. It is above. Tragus is this one. Above is hallux. In between, I am showing you some area. This is incisura terminalis. This is incisura terminalis. What is the use of incisura terminalis? Everyone, you can do this experiment. You take your little finger, you keep between tragus and hallux. So this is incisura terminalis, used for Lambert incision. Lambert incision. Clear? It is for Lambert incision. And then, which we have discussed, used for pediatric patient. It is Lambert incision. Then they can ask you one integrated MCQ on external auditory canal. External auditory canal and TMJ. Everyone, this is again a very crucial slide, clinical MCQ, and with the help of this we are reading must read segments better, where they will make integrated question of anatomy with ENT or physio with ENT. They can ask you which communication is there. So if you touch your external auditory canal, just come 1 centimeter below. If you come 1 centimeter below, there is a TMJ, temporomandibular joint is there. So your external auditory canal is communicating with TMJ, temporomandibular joint. These are fissure of Santorini, foramen of Husky. Worth remembering point, fissure of Santorini, it is in the cartilage part. Foramen of Husky, it is in the bony part. So just remember, it is in the bony, one is in the cartilage part. Then clear? Is this concept clear? Coming to the next one, question number 4, integrated question of ENT with ear pathology. Which of the following is the most common type of congenital ossicular dysfunction? So beta यहाँ पे हमें कौन सा build up करते हैं? Always remember congenital. Underline this word congenital. Always remember congenital anomalies. If examiner asks you congenital anomalies, they are always remember they are multifocal. This point you must have read in pathology. So patho books mention that any congenital anomaly is multifocal. Like if my malleus is involved, my incus and stapes cannot be spared. If stapes is involved, other ossicle will be definitely they will be involved. So it is not one single ossicle, it is multiple ossicle. Same concept in the inner ear. If your cochlea is involved, your vestibule cannot be spared. So whenever there is some involvement, congenital involvement of cochlea, even vestibule is involved, and what we call it as congenital dysplasia of the cochlea with vestibule, we use the word Ship's anomaly. So I can make a important concept for you. Most common congenital anomaly, if examiner asks you about middle ear, it is your multiple ossicle fixation. So option 2, second option is the best option. It is multiple ossicle. It is not one single ossicle. It is multiple. And if examiner asks you about inner ear, the most common congenital anomaly is your Ship's anomaly. So beta हम 3 points याद रखेंगे. We will remember 3 points. One is congenital anomalies are multifoci. One is most common congenital anomaly of middle ear is multiple ossicular fixation. One is inner ear is your Ship's anomaly. Done? Is it clear? Let us use this MCQ to crack the anatomy part of your middle ear. Always remember the most important wall, if you ask me, they are your anterior wall and the posterior. Posteriorly we have already discussed. There is communication known as adductus, and I always give a mnemonic to my students on the anterior wall. Just remember, we all together we have a cup of tea. So just remember important structures. Which are the important structures on the anterior wall? It is one is attachment of tensor tympani, one is your ET tube, eustachian tube, one is artery. Which artery? That is carotid artery plexus. Clear? Any student who can tell me from this carotid artery plexus which nerve is going, which is this nerve? Yes, anyone? This is your Arnold nerve, which is going on the promontory with your jugular bulb. From the below there is one Jacobson nerve coming. Clear? Chalo, I take you to the next level. I'm showing you the slide. Find out the error in the slide. Anyone, any student who can tell me the error in the slide? They can ask you these type of MCQs. Is there an error in the slide? Yes. Any student who can find out the error in the slide? Because this is my stapedius. Stapedius is not attached with the round window. It should be attached with the oval window. This is the error in the slide. Very good, Dr. Shreya. Excellent. The fastest reply. Dr. Shreya, it is here. Oval window should be attached with stapedius, not the round window. Clear? Question number 5. A child with a history of URTI with mouth breathing and impaired hearing. This is again a very old MCQ of your NEET examination. If the patient is having serous otitis media with impaired hearing with recurrent attacks with mouth breathing and impaired mouth breathing, patient school going child is going in the favor of adenoid hypertrophy. With impaired hearing, one of the cause for serous otitis media. So if a child with the examiner is showing you one tympanic membrane, over there are small blebs, we call it as blebs with hearing loss. If there is some blebs with hearing loss, it is your serous otitis media. What is the treatment now? Tonsillectomy? Not at all. Grommet insertion? Yes, we will do. We'll go for grommet. Now which is better option? Laryngotomy with grommet or adenoidectomy with grommet? So better option will be adenoidectomy with grommet, because when we are doing adenoidectomy, when we are putting the grommet, so definitely we are doing laryngotomy. The word grommet insertion itself include कि laryngotomy procedure is being done. So best option will be here option D. Option D will be the best option. This is a typical presentation of blebs beta. This type of slide will be shown to you. I will be going, if the patient is having serous otitis media, serous glue ear, I will be going for laryngotomy with grommet. Where? Which part? Yes, any student who can tell me which part we will be putting grommet in anterior inferior segment. Laryngotomy and grommet insertion in anterior inferior segment. Patient not responding for how many months? Any student who can write in the chat box. How many months? Patient not responding. Patient not responding for 3 months. If patient is not responding for 3 months, then I will go for grommet. Am I understandable? Just remember this point. Patient not responding for 3 months, will go for grommet. This is a small ventilated tube. Where we put the grommet? Anterior inferior. We put the grommet in anterior inferior. So this is one of the easiest question. From here, serous otitis media, I am taking you to ASOM, acute suppurative otitis media. Worth remembering point, in acute suppurative otitis media, बेटा 2 पॉइंट याद रखने हैं, worth remembering point. They will ask you the cartwheel appearance. Either they will ask you cartwheel appearance or they ask you lighthouse sign. If they ask you cartwheel appearance is seen in which stage? It is seen in stage of pre-suppuration. And if the examiner asks you lighthouse sign is a feature of stage of suppuration. Okay, so these are the two important points: lighthouse sign in pre-suppuration, cartwheel appearance in pre-suppuration, lighthouse sign is stage of suppuration. What is the treatment of ASM, acute suppurative otitis media? We have to start antibiotics because it is streptococci, but here we are not putting grommet, so just remember it will be your antibiotics with myringotomy. Where we give the myringotomy? Any student who can tell me where we give the incision for ASOM, acute suppurative otitis media? We give the incision in posterior inferior. Serous otitis media, anterior inferior. Here I am giving a circumferential incision. So what will be the treatment for this? This will be a posterior inferior. So I will be giving a posterior inferior incision on the in patient of ASOM, acute suppurative otitis media. Done. So these are the first 5 MCQs with which we have learned basic anatomy part, some physio segment. Clear? These are the must read topic. But motive of these 20 MCQs to give you a vision of how to proceed for integrated learning. Coming to the next one, little bit difficult here, but we all together will crack it. Let us read. A 60-year-old male coming to emergency with a 2 days history of worsening ear pain drainage. On the day prior to presentation, the parents noted redness behind his right ear, and right ear appeared to be sticking out. Well, until 10 days ago when he started complaining of a cough, running nose. Patient examiner is giving you a typical history of your ear pain with drainage, ear discharge, CSM, chronic suppurative otitis media. Okay, and there is a running nose which precipitate ear pain and fever. He was placed on amoxicillin. Initially appeared to improve until 2 days ago when the patient got severe attack of this ear pain. Now ear discharge, redness behind the right ear, prominent pinna pointing out. Yes, not responding to the medical treatment. Patient was planned for a surgery. Now you tell me, this history is going in the favor of any student. This whole history is going in the favor of a CSOM patient, chronic suppurative otitis media, not responding to the medical treatment. If not responding to the medical treatment, what I will go for surgery. Any student who can tell me what is the treatment for CSOM, treatment for chronic suppurative otitis media, will be your mastoid. So it was planned for the surgery. Identify the pointed structure. Now examiner is giving you a slide in which we have to identify the pointed structure. Clearly visible, this is my tympanic membrane, one of the best slide of, you can say, ear, where we can dissect each and every concept. So examiner is doing mastoid surgery. He have written the plan for the surgery, identify the pointed structure. So examiner is opening the mastoid. So now tell me, I'm waiting for response in the chat box, beta. Let us integrate the complete anatomy with the help of this slide. Dr. Sagar, you are giving the best reply, but which canal, which semicircular canal is visible to you? You have opened the mastoid. If you have opened the mastoid, which slide is visible to you? This is your lateral semicircular canal. Lateral semicircular canal. Clear? It is your lateral semicircular canal. Now I have given you 4 options: sigmoid sinus, Sethi angle, aretus. Let us attempt all the 4 in the slide. Beta, where is my sigmoid sinus? Number one, this is my sigmoid sinus. Number 2, Sethi angle. What is Sethi angle? Sethi angle is your sinodural angle. Sinodural angle. Every student sitting with me should reply Sethi angle. Number 2 is your this area. What is number 3 is your semicircular canal. So this area is my lateral semicircular canal. This area which I am showing you is your lateral semicircular canal. And number 4, number 4 is your aretus. This is my aretus. Okay, this is aretus. All the students who are attending this session of mine for the first time, they are not comfortable with the anatomy. I will explain you better. Concentrate on the board. This was my lateral wall. I am standing in front of you. This is my lateral wall. I remove the lateral wall. So if I want to open the mastoid, everyone take your finger, keep behind mastoid. This is area I open. When I open the mastoid, I see the mastoid cavity. So this is anterior. This area is anterior. This area is posterior. So this plate is sinus plate. Why? Because your sigmoid sinus. This sigmoid sinus behind. So it is sinus plate. Above is your dural plate. Just remember dural plate. Angle. The angle between the sinus and the dural plate. That angle is known as sinodural angle. This sinodural angle, the other name is Sethi angle. Option 2, I have given you Sethi angle. This angle is acute. Always remember. In a normal human being, sinodural angle, Sethi angle is acute. But if there is a CSOM, like in this patient, there is a high probability in future the necrosis, damage to the posterior wall, so sinodural angle will be changed to obtuse. This is a very important concept of Central Institute. In normal human being, the angle is acute, but in case of a CSM, it is converted to obtuse. Then this is, I'm showing you nice radiology slide for middle ear mastoid. Better just try to learn the structures. You concentrate on this area first you concentrate on every student sitting with me, focus your eyes on this area. This is my ossicle malleus head. So if this is malleus, on the other side you can compare. If number 1 is malleus, what is number 2? Number 2 will be definitely epitympanum. This area is your epitympanum. Then number 1, number 2. Now behind middle ear, this is anterior. Who told you this is anterior? So TMJ is visible to me. Temporomandibular. From anatomy to ENT, I am taking you into the radiology segment now. Now focus your eyes on the mastoid. Wherever you are seeing this pointed area, this, the number 3 is my semicircular canal. Can you see this semicircular canal? And then there will be vertical part of facial nerve coming down. Clear? So lateral semicircular canal is equal to, what is my formula of ENT? Lateral semicircular canal is equal to medial wall of mastoid. Medial wall of mastoid. Always remember this formula. Which two formulas of anatomy will give you multiple MCQs? Two important MCQs, beta. Just listen carefully. Base of cochlea. Base of cochlea. NEET 2021. Base of cochlea is equal to medial wall of middle ear. Medial wall of middle ear. And lateral semicircular canal is equal to medial wall of mastoid. Just remember these two formulas. Thumbs up in the chat box, beta, if you are comfortable with these two concepts. Medial wall of mastoid is equal to lateral semicircular canal. If you're going for, dekho beta, you are sitting with me on this platform at 9:30 you are attending this session. It means you are fully dedicated student and your aim is to crack your Central Institute. If you're going for Central Institute, this is my pinna, middle ear, mastoid. This is middle ear. Medial wall of middle ear is cochlea. That is base of cochlea. Here will be my utricle saccule and here will be semicircular canal. So just remember this point. Medial wall of mastoid. Medial wall of mastoid is equal to lateral wall of semicircular canal. Lateral wall of semicircular canal. Done. So this level of basic anatomy should be on your tips. Coming to the next level, I will be using this question number 6 as an opportunity to discuss few landmarks with you. If you are going for examination, Mac-Evans triangle is for mastoid surgery. Mac-Evans triangle for mastoid surgery. Donaldson line, always remember, Donaldson line is used for endolymphatic sac. And one is facial recess. Facial recess, it is used for posterior tympanotomy. Posterior tympanotomy. But it was 10 days history of acute symptoms. Patient may have the hidden, you can say, infection of middle ear mastoid, but patient was having severe symptom for the last 10 days only. It is not like CSM is having only 10 days history. It was aggravated symptom since last 10 days if you go in the history of the patient. Clear? Coming to the next one, question number 7. I want everybody should reply. A 5-year-old patient present with a history of hearing loss. On examination, he found to have pearly white mass behind the intact tympanic membrane. What is the most probable diagnosis? Yes. Hearing loss. 5-year-old child. 5-year-old child. Pearly white mass. Spot diagnosis. Pearly white mass. 5-year-old. It is your congenital cholestroma. Congenital cholestroma. Done. So let us dissect this MCQ. Automycosis. What will be the keyword for automycosis? I can write in front of this. The examiner will give you a typical wet newspaper like appearance. Typical history will be wet newspaper like appearance. Autosclerosis. There will be pregnant female. Carhart notch. If I give you like which will be the 4 keywords in the MCQ, I will make a diagnosis of option C. That will be pregnant female, Carhart notch, Schwartz sign positive, and airborne gap. Again, listen to me, with airborne gap given in the MCQ, Carhart notch is given in the MCQ, Schwartz sign is given in the MCQ, pregnant female is given. Out of these 4, anything is given, I will be going for option C. Very good, very nice, Dr. Sakshi. Excellent. It is wet newspaper like appearance. Exosteosis. What is exosteosis? Surfer ear. Absolutely. Very good. Excellent. Nice. Every student is responding in the chat box. It is your swimmer's ear. If the examiner gives a typical history of patient cycling, habit of cycling, swimming or surfing on the beaches, the patient will be having bilateral osteoma formation. What is bilateral osteoma formation? That is your exosteosis. So in this MCQ, answer will be your option A. That. Coming to the next one, match the following. Nice. This is a nice question. There is one motive behind this question. Now I want to discuss with you, that is your acquired cholestroma. Congenital cholestroma is this question number 7. And one more important point for congenital cholestroma, which criteria is used. If you are going for central institutes, they will ask you this point, Levinson criteria. Beta, I understand all these students, the 3rd year student or 2nd year student who are listening to me, and you will be going for next examination, all the classification, all the criteria will be very crucial. Clear? So Levinson criteria is something to do with congenital cholestroma, and Levinson criteria have 4 points. Just remember, the first point is pearly white mass. There is white mass in a pediatric patient. Pearly white mass in a pediatric patient. If you want to make a diagnosis, of congenital cholestroma, always remember, there should be no history of ear discharge. Any student who can write in the chat box, Levinson criteria, explain congenital cholestroma, there should be no history of any ear discharge. Why you're ruling out? What you're ruling out? There is no history of ear discharge, means you are ruling out secondary cholestroma. Just remember this point. If there is no history of ear discharge, means you are ruling out secondary cholestroma. Your book says there is no history of any autologic procedure. It means what you're ruling out? You're ruling out tertiary cholestroma. But Levinson say that there can be history of otitis media. Otitis media can be there. So we have 4 points. Pearly white mass behind tympanic membrane. No history of ear discharge. No history of any otologic procedure. But history of otitis media can be there. Done. Coming to the next one, question number 8. What is the motive of question number 8? Classification. Many criteria are there. Many classifications are there which we people are using. No otologic procedure. It is your tertiary. Clear? Now, what is the motive of question number 8? The motive of question number 8 is here to give you a message. Secondary, just remember this point. Haberman theory is a theory which explains secondary cholestroma. Just focus, all the students. Haberman theory. is something to do with migration. This is my external auditory canal. This is my middle ear. And if I want a squamous cell in the middle ear and there is an opening, if there is a perforation, secondary cholestroma, the squamous cell move inside. So just remember this point, beta. अगर कुछ याद नहीं भी है तो just remember Haberman theory is epithelial migration to A. So I can rule out these options. I can go with the option A. So I have three theories which explain my primary cholestroma. I will be coming on this slide in next 5 minutes. First, we were learning important theories. So if secondary theory, just remember secondary cholestroma is explained by Haberman theory, while primary cholestroma is explained by your Whitmack, Rudy and Sethi. What is Whitmack theory? Is your theory of retraction pocket. Rudy's theory is your basal cell hyperplasia and Sethi is your squamous metaplasia. These are the important theories, beta. Even if you can't mug up each and every point, just learn Haberman theory is epithelial migration. So whenever there is a cholestroma, what is cholestroma? All the second year student, if you're attending the session, cholestroma is metaplasia of eroded epithelium. So they can ask you an integrated question of patho. So this is complicated pus. There is a metaplasia of eroded epithelium, like there is a pus in the middle ear. The pus want to damage the bone. It will erode the epithelium. So cholestroma word, there should be metaplasia of eroded epithelium. Now I'm showing you next two slides. The first slide is for most common site. Anybody who can write in the chat box, most common site and earliest site. Most common and earliest site for cholestroma formation is Prusik space. What is Prusik space? Prusik space is space between tympanic membrane. It is space between tympanic membrane and malleus. This is my tympanic membrane. This is my malleus. So this area which is above malleus and below tympanic, pars flaccida, just below pars flaccida, above malleus. This is your Prusik space. That is your most common site for cholestroma formation, earliest site for cholestroma formation. Next slide, I am showing you a area which is behind all window. But this is anterior part. This is, I'm talking about medial wall. So on the medial wall, behind all window, there is a important small pouch, you can say small sinus. That sinus is most common site for reoccurrence. So from anterior to posterior, just try to learn better. This is anterior to posterior. Most anteriorly here will be processus cochleaformis, and behind processus cochleaformis is oval window. Behind oval window is sinus tympani. If I draw a simplified line diagram, this is my promontory. This is what I'm seeing from above. Actually, this is something I'm seeing from above. This is my superior inferior section. Superior inferior. This is anterior. This is posterior. So just remember this point. Okay, on promontory, Dr. Divya, I'm coming to a query in next 1 minute. Let me draw this line diagram. This is processus cochleaformis. Behind processus cochleaformis is oval window. Below oval window is round window. And behind oval window, this area is my sinus tympani. So what is sinus tympani? A small groove is there. This groove is the most common site for residual. It is very sinus. The word sinus is giving you the message. It is very small area. Because it is small area, it is difficult to clean. And if it is difficult to clean, we always leave something. So it is the most common site for residual cholestroma. Most common site for residual. If we leave something, it reoccurs. So just remember, Prusik space is equal to most common and earliest. Sinus tympani is reoccurrence and residual. Now coming on one of the query, Dr. Divya, epitympanum is Prusik space. False statement. Prusik space is a part of epitympanum is true. This is complete epitympanum. This complete area is epitympanum, out of which a small segment which is between head of malleus and pars flaccida is here Prusik space. So Prusik space is a small part of epitympanum is a true statement. Clear? Now I'm showing you two slides. So let us do some visual MCQ. Now after making all these basic concepts, I will ask you, what is the diagnosis? What is the diagnosis? Which cholestoma? This one first. Which is the second? This one, second cholestoma. First is a slide of a 5-year-old child, and the second is a slide of 50-year-old child. Can you tell me which cholestoma? Yes, reply in the chat box. The slide number 1, there is pearly white mass in a 5-year-old child. Slide number 2, pearly white mass behind tympanic membrane. You are seeing a nice perforation in the attic area. You are seeing a nice central perforation. This patient was, how can you make this diagnosis? Will be tubotympanic patient. This was tubotympanic with complicated to atticoantral. Clear? Always make a concept better. If the examiners show you only disease in the lower part, it is tubotympanic. If the disease is in the upper part, it is atticoantral. So beta, slide number 1. I am waiting for response in the chat box. Very good, Dr. Suprit, excellent. The first is congenital cholestoma. Slide number 2 is your secondary cholestoma. First is congenital cholestoma. Dr. Shreya, no, it is not CSM, it is secondary cholestoma in slide number 2. Slide number 1 is pearly white. That's very good. There the best answer comes from Dr. Divya. The congenital rank your first slide, and second slide is your secondary cholestoma. Clear? These are the important points. Now I am showing you this nice orientation of sinus tympani. Better now concentrate. Very important MCQ. I am showing you 3 slides. Better, this is the future. They will be asking you all these 3D MCQ integrated question of ENT with anatomy. This is slide A, this is slide B, this is slide C. I'm waiting for response in the chat box. Can you tell me, out of these 3 given slide, patient will have very poor prognosis in which slide will have very poor prognosis? Common sense, apply your common sense, reply in the chat box. Yes, A, B, C. Who will be having very poor prognosis? A, B, C. Who will be having very poor prognosis? C. Excellent. Yeah, excellent. Dr. Samya, Dr. Yes, excellent. C will be poor. Why? Because you have a deep sinus tympani. Where is the sinus tympani? Sinus tympani is behind oval window. I magnify the slide. Now label the structure. Can you label number 1, number 2, number 3, number 4? If you can reply, my aim is over. I'm making you master of anatomy with the help of my ENT slides. What is 1, 2, 3, 4? Any student? Kindly respond in the chat box. What is 1, 2, 3? Very nice. I'm very happy. Everybody is responding. Right answer, number C. Very deep sinus tympani. It will be difficult. It will be difficult to clean sinus tympani in slide number 3. It will be very difficult to clean. But honestly, it took lots of art to make all these MCQs for all these slides, compiling all these points so that you people get each and every bit of basic science which is required for your next examination. Tell me, yes. Number 1 step is very good. What is the formula we discussed in the classroom? Classroom में हमने concept याद किया था, alphabet C. Look for alphabet C. Alphabet C is your step is. Yes. What is number 1 step is? Number 2. Yes. Any student? Still no perfect reply in the chat box. Dr. Sagar is great. Directly he jump. Okay, sir, number 4 is facial now. Very good. Number 4 is facial. Absolutely true. Number 2 is tensor tympani. Absolutely right. Number 3 is processus coccoliformis or pyramid. Dr. Sagar, Dr. Sunil, it is processus coccoliformis or pyramid. Number 3 is pyramid now. Number 1 is stapes. Suprastructure of the stapes. Number 2 is your stapedius. Number 2 is stapedius. Number 3 is the attachment of stapedius, that is pyramid. Number 4 is your facial now. Number 4 is your facial now. Then I hope everything clear, crystal clear. Where this slide can be used to revise anatomy in a nice way. Concentrate on the board now. Concentrate. Let us learn next level of anatomy. Yes, anyone? What is this I am showing you? Yes. What is anterior? This is anterior to oval window. So this will be the tendon of your tensor tympani. Coming to the next level. Yes, this is again a nice slide. Now, all the students preparing for Central Institute, let us do mastery of this slide now. Prussic space. How the cholestroma spread. The cholestroma start from Prussic space. It spread to 3 areas. All the students, please write this in your notes. This is a very high-yielding slide I'm showing you. The slide, the cholestroma from the Prussic space, it spread into 3 areas. First, revise with me. The one is mesotympanum. How to revise? I will help you. First, you revise mesotympanum. I will write how to this cholestroma spread. This cholestroma spread to mesotympanum. It spread to epitympanum. Again, epitympanum, it spread to the anterior part of epitympanum. It spread to the posterior part. It spread to the anterior part of epitympanum, posterior part. So just remember, this is a little bit difficult, but you all together will crack it. The cholestroma spread to mesotympanum, epitympanum. Epitympanum, it spread to anterior part of epitympanum, posterior part of epitympanum. Now, how it spread to the posterior part of epitympanum? Just remember, incudal space. It spread to the posterior by incudal space. Where is the incudal space? It will be, this is actually known as superior incudal space. It is superior to incudal, that is incus, fossa incudus. So from the upper part of incus, it spread to the posterior part of epitympanum. पहले तो बेटा ये चीज याद करो. The cholestroma, how cholestroma enter into the posterior part of epitympanum? It enter via incus. Just remember this point, via area above incus. Now, how it spread to the anterior part of epitympanum? How it passed to the posterior part? So there are some pouches, anterior pouch, posterior pouch. Anterior pouch of Trollesch, posterior pouch of Trollesch. So just remember, it go to the anterior part of epitympanum by anterior pouch, and it go to the mesotympanum with the posterior pouch of Trollesch. I will help you again. Cholestroma from Prussic space enter into, beta, this is a next level of anatomy which you should be aware if you're going for next examination. Cholestroma enter into 3 areas: mesotympanum, epitympanum. 2 parts of epitympanum. Anterior part of epitympanum, posterior part. It enter into the posterior part via incus, above incus, and it enter into the anterior part via anterior pouch of Trollesch, and it enter into the mesotympanum via posterior pouch of Trollesch. Am I understandable? Again, I am repeating. Cholestroma spread into, first of all, just remember, it is going into posterior part of epitympanum via area above incus. First remember this area, then you can easily crack mesotympanum and anterior part. Clear? Yes, superior, that is a plane, beta. That is a plane, the area which is superior incudal space. It is 3D image. Actually, it look like it is away. It is not away. It is. So this slide, this part is very important. Cholestroma enter into the posterior part via incudal space, and anterior and posterior via pouch of Trollesch. Done. Very nice slide in front of you. Identify. Number 1. What is number 2? What is number 3? Yes, fast. Number 1, 2, 3. Hardcore anatomy of middle ear. What is the concept we have learned? Alphabet C. Alphabet C is equal to stapes, and wherever the stapes is attached, so definitely that will be the oval window. That is my inner ear. That is my promontory oval window. If this is the oval window, what is this? Round window. Which is there? Below is the round window. Oval window, then is a round window. Clear? Coming to the next one. Question number 9. Study the given image and choose the most appropriate statement regarding the pathology related with the given surgery. Now what I am showing you, I am showing you a slide where I am using the word dural plate, sinodural angle, sigmoid sinus. You are master of the game. If these words are there in the surgical field, the examiner is using these words, it means he is talking about mastoid. तो बेटा हमने क्या खोल रखा है? We have opened the mastoid. It means the MCQ is related with the mastoid surgery. We are operating the mastoid. Let us read the option. Anyone? Option A. This is hardcore clinical MCQ of your ENT. Extradural abscess is the most common complication. Absolutely blunder. Which is most common complication? Most common complication is mastoiditis. Extracranial, most common overall mastoiditis. Done. Is a false statement. Combined approach tympanoplasty. Combined approach tympanoplasty is a canal wall up procedure. Type of mastoidectomy. Canal wall up, canal wall down. Canal wall up is of two types. One is cortical, one is combined approach. So this is a true statement. But before going for option B, always make a habit to read all the options. You should be confident to rule out other options. Tobbe-Ayer sign is a CT finding. What is Tobbe-Ayer sign? Tobbe-Ayer sign, you press your jugular and there is no increase in CSF pressure. Which patient? Lateral sinus thrombosis. So lateral sinus thrombosis, when you press the jugular, there is no increase in intracranial tension. Is a CT finding or clinical finding? Is a clinical finding. Is a clinical finding. Patient is suffering from serous otitis media. If patient is suffering from serous otitis media, will you open the mastoid? Mastoid. So it means false statement. Option C false. Option D false. Combined approach tympanoplasty is a canal wall up procedure is absolutely true statement. Clear? So mastoid surgery, always remember, mastoid surgery is of two types. One is canal wall up, one is canal wall down. Canal wall up. What is canal wall up? One is cortical mastoidectomy. Cortical. One is CAT surgery. Combined approach tympanoplasty. All the students listening to me, beta dhyan rakho, isme tympanoplasty we are keeping the graft. So very minimal disease. When rest of the mastoid, rest of the middle ear is normal, we can take the risk of combined approach tympanoplasty. Rarely we do. We always prefer most common surgery. Which is the most common surgery? In CSM, canal wall down. Which canal wall down? Radical mastoidectomy or modified radical mastoidectomy? Always remember, we are doing modified radical mastoidectomy. What is the difference? It should be on your tips. Radical, remove everything. If I remove every remnant, I block the ET tube, it is radical. And if I preserve the normal, if I never block the ET tube, if I don't touch the ET tube, I'm not blocking it, it is MRM, modified radical mastoidectomy. Clear? Any student who can write in the chat box where we will prefer radical, in which patient we do radical? Anyone? Any student who can tell me where we do radical? Beta radical, only one indication, that is malignancy part. In malignancy, if there is a malignancy, mastoid, carcinoma mastoid or middle ear, we prefer radical. We prefer radical. That. Any query on this MCQ? Nicely formatted. Lateral sinus thrombophlebitis, very important. One is your most common intracranial, like mastoiditis is extracranial complication. Examiner can ask you intracranial. Intracranial, most common is meningitis. Second most common is brain abscess. Very big controversy. Don't waste your time on controversial point and just try it. And take my word, beta, all you students listening to me on this platform, whether whatever is the pattern, whether you're going for NEET, you're going for NEXT, you're going for INI-CT, just remember, qualitative learning is the key to success. Qualitative learning. Read less, revise more. These are very vast things, beta. It will not be retained unless you will revise 4 to 5 times. 4 to 5 times, beta. So just try to make very concise notes and revise it again and again. Doable things करनी है बेटा. What most of the students are doing, I'm sorry to share on this platform. If in a day, if only 10 things are possible, and if I make a target of 100, unachievable, then I will end up with 10. I am giving my best performance because in a day 10 things can be done and you have done all the 10 things, but you are running behind a quantity where 100 things are given to you. So you can't, at the end you end up with a low confidence care. I'm not completing the target. Make that things, make those notes which can be properly revised. So if we make a proper concise notes, उनको बेटा हम बार बार revise कर पाएंगे. Clear? And if you just go on reading without any revision, take my word, at the last there is a blast. So it is better we should concentrate only on concise notes. Take my words, concise notes. 20 years पहले भी यही मेथड था, concise notes. आज भी ये मेथड है. अब हम ना we ourselves we are making the things complex. हम सब कुछ पढ़ के अपनी चीजों को complex कर रहे हैं. Just try your best to make concise notes. Thumbs up in the chat box. Make a promise to me कि बेटा go with the concise notes. Revise them again and again if we want it ranked. Clear? ET tube modified MRM ET tube beta modified radical mastectomy. We never block the eustachian tube. We remove the abnormal, but we preserve the normal. We preserve normal. But in radical, even normal tissue is there, we remove it because it is carcinoma patient, and we block the ET tube. In modified MRM, ET tube is not blocked. Here, radical ET tube is blocked. Here, it is not blocked. Clear? Is it clear? Query? Lateral sinus thrombosis, 4 important points should be on your tips. One is edema. There will be edema in every corner. Edema over the mastoid, Graysinger sign. Edema over the eyes will be known as Crowback sign. All these signs should be on your tips. Tobe here we have already discussed. Graysinger is edema over the mastoid. Picket fence fever, spiky fever. Spiky fever is a feature of lateral sinus thrombosis, lateral sinus thrombophlebitis. Clear? One more MCQ I have taken from the segment of this mastoiditis. Mr. Ramesh with history of ear discharge, ear pain, retroorbital pain is there. MRM was done to him. Patient come back with persistent discharge. What is the diagnosis? Beta retroorbital pain. It means we are talking about something very posterior. Retroorbital. It is ear discharge with 5th and 6th now. Palsy. Patient have ear diplopia, modified radical mastectomy was done. Diplopia history is not there. I can ask you one and more MCQ in this question. Which of the following symptom, more symptom, one, which other symptom is expected in this patient will be diplopia. Retroorbital pain means deep-seated pain. And whenever there is a deep-seated pain, we suspect 5th nerve, trigeminal neuralgia. In the same patient, we will be looking for diplopia, 6th nerve. That is your petrous bone involvement. And what will be the investigation of choice? Anyone who can make a investigation of choice, what will be the investigation of choice of this patient? Investigation of choice of this patient will be HRCT. Will be HRCT. Clear? Just remember this concept, beta. If there is a fluid in the middle ear, if there is a fluid in the middle ear with a 5th nerve and 6th, this is your Grad-Negro syndrome. Which patient we are talking about? Petrous bone. If it is fluid in the middle ear with 5th and 10th nerve palsy, anyone who can write in the chat box, instead of 6th nerve, if it is 10th nerve, then I am making a diagnosis of yes, it is tortoise triad. 5th and 10th is tortoise, will a feature of nasopharyngeal carcinoma. So difference is of 1 now. Here we have 6th now, there we have 10th now. Here the investigation of choice is here CT, HRCT. Here investigation of choice is MRI. Just remember this thing. Clear?